Okay, this is a lecture for psychiatric medications. Um, Overall, I have, at least decently liked the layout of this book. The psychiatric section's kind of weird, which is funny because it's a psychiatric section. Um, there, I will tell you this: don't ever think of a psychiatrist as a shrink or someone who's not a real doctor, or whatever. Psychiatrists, physicians, psychiatric nurse practitioners, these are specialists in the area of mental disorders, the same as a cardiologist is a specialist in the area of the heart. So, the reason I say that is don't ever forget the importance of having a psychiatrist manage psychiatric illness. I promise you, unless you're a psychiatric nurse practitioner or a psychiatrist, you don't know nearly as much about it as you think you do. And that can be dangerous to the patient. Is probably one of the most poorly treated areas in medicine, uh, mainly because it's difficult to deal with, and a lot of times we don't want to deal with it, or we don't have the knowledge to deal with it. Believe me, I deal with plenty of psychiatric issues in the hospital, and I will start them on some things, and I'll counsel them this and that. But I've developed some great relationships with psychiatrists, and I'll get them referred as quickly as possible because they need to be managed correctly. Okay, so remember that you're not a psychiatrist. Don't be trying to do it yourself. And I was not able to kill the fly without damaging something in my office. My plan is to suffocate him overnight. Okay, so on page, this is chapter 15. It starts on page 268. Well, I want to break it down. Let's talk about depression first, okay? That's something that is okay for you to start management of and potentially manage at certain levels. Okay, uh, one of the main groups of medications used right now are the selective serotonin reuptake inhibitors, Prozac, Paxil. Um, these do exactly what they say they do. There's not enough serotonin getting across at the neuronal synapses. And when the serotonin is not transmitted across, it's reabsorbed. So this prevents the reabsorption so that more serotonin can get across. This improves mood, stabilizes mood. Now, it comes with side effects, and they can be the side effect is actually a side effect of improving a person's mood. On commercials, you always see this may increase thoughts of suicide. Well, here's how it does that. It doesn't make you more suicidal. It actually gives you the energy to actually carry through with a plan if it was not an adequate treatment. That's a fine example of why psychiatrists need to manage this. If someone has major depression and they have not spilled their guts to you about what's going on, and you've convinced them to let you start them on Paxil, and they go home and kill themselves next week, that's your fault, really. I shouldn't say it's your fault. It's not your fault. But that's just how serious I am about making sure these people get adequate treatment. It's a topic near and dear to my heart. But I don't practice psychiatry, which is strange. So, selective serotonin reuptake inhibitors are good to start with. I like Paxil because it has a shorter duration, so it's easier to start on, it's easier to get off of. Prozac is a really good one. We're talking more for people with more major depression. Um, it has a longer action, takes longer to get in the system, but it works very well. They all have titratable doses to effect, of course, and of course now the main side effect of most all antidepressants, of course, is sexual dysfunction. There are many who have an indirect side effect of weight gain because people are feeling good, so now they feel like eating. Um, that starts on page 279. Just review those. quiz question will probably be to the tune of, this patient, I'm going to describe some symptoms of not so major depression, and before you refer them to the psychiatrist, you may start them on which of the following. Something like that, okay? Tricyclic antidepressants, I don't use those at all, if at all possible. That's a region for psychiatrists as well to determine when those are absolutely necessary, because you will cause a whole host of other problems for the patient by prescribing those, especially if your patient has any cardiac issues, okay? So stay the heck away from those. They will induce deadly arrhythmias if not used correctly, okay? But they do have their place, and that's why I recommend that psychiatrist actually is prescribing with this. So know that about deadly arrhythmias. That would be a good quiz question. And actually, I saw that on page 278. Okay. On page 282, it talks about trazodone that I talked about in the last lecture, used as a sleep aid. Here's how I like to use this. People with depression are either hypersomnolent or insomnolent. And trazodone actually works well for both. So what I do is I don't just, if someone's having a sleep issue on top of depression, I may prescribe, let's say, Prozac and trazodone, because trazodone will help get a better sleep pattern going, even if they are hypersomnolent, because that'll change once the actual antidepressant starts working. And trazodone is in the class of selective serotonin reuptake inhibitors, but by itself it's not a very good antidepressant, but it is a good sleep aid that does have antidepressant properties. So it's okay. I like to prescribe that along with another more potent selective serotonin reuptake inhibitor. Okay, so that, don't be surprised if you see trazodone come up in a question to that effect. Okay, that would be the one sleep aid question I'd ask you about, because I said in the last video that I want to ask you about sleep aids. So trazodone is the exception. On page 283, it talks about Remeron, which is a tricyclic antidepressant. I don't prescribe much of that. Again, that's something for the psychiatrist to do. The only case that I do prescribe Remeron, this is an off-label thing, and this is just FYI. I'm not going to put it on the quiz. It can be useful for appetite stimulation in people with dementia or psychiatric disorders. Okay. Okay. Then the book kind of gets into bipolar depression. And it's bipolar depression more so than bipolar disorder. It really could be either. So people who have long periods of depression and intermittent periods of mania or hypomania. Mania is for bipolar type 1. Those are the people that absolutely go crazy and buy 20 Cadillacs in a day because they feel that good. Hypomania are the people who do completely bizarre things they would not ever do, but not quite to that effect. Okay, so in the last lecture I was talking about how people with migraines may have bipolar disorder, or people with seizures may have bipolar disorder, because there's a lot in common. So a lot of the seizure anticonvulsants can be used for the treatment of bipolar disorder, such as Lamictal, Tegretol. Now, other medications that can be used, and this is more for bipolar type 1, is lithium, okay? Now, lithium is a salt, all right? So what is important to know about lithium, because you may have people who are taking it, is you'll sweat it straight out your body, okay? People with bipolar depression type 1 in the summertime will go crazy if their lithium is not monitored closely, okay? They got to have enough of it. The other thing is lithium toxicity, the exact opposite situation. And this you will recognize by neuromuscular depression, obtundation, and the treatment is quite simple. You hold the lithium and flush the system with IV fluids. That's a hospital situation, okay? But lithium if you're ever suspicious of anything during a patient's hospital visit, or I mean a clinic visit, and they have some weird complaints of that seem to be neuromuscular in nature, always draw a lithium level. That would be a good thing for you to do. So, lithium question. Even though we're not psychiatrists, I might say um, it's June in Arkansas. This patient with bipolar type 1 takes lithium. Which of the following actions might be appropriate? And of course, the answer would be we may need to increase the patient's lithium depending on symptoms, okay? Because people get out and try to enjoy their lives because they're on lithium and it makes them feel okay. And then they do what everybody does in Arkansas in summer, and you sweat, and guess what? Salt goes out through your sweat, and then you don't have enough lithium, and then you're having a really good time until you come down, okay? Lamictal, Tegretol, and valproate. Those are good mainstays for treatment of bipolar depression. Um, they are all membrane stabilizers. They're also used for anticonvulsion. Um, so just review those. Those are also on the next pages, 285, 286. There's a spotlight on bipolar disorder on page 286. Review that. Depression also comes with anxiety. Anxiety can also be its own issue.